Good afternoon, all. I'm Dr. Prateek. I'm a senior resident in the Department of Psychiatry, working with the Community Psychiatry Unit here at NIMHANS. I hope you all are keeping well and staying safe. As we all know that the COVID-19 pandemic is ongoing and many of our known family members or friends might be affected by COVID. And to highlight that because in the wave of COVID pandemic, there has been a shadow pandemic going on of psychological distress. Subsequent to individuals who have COVID are in isolation, quarantined, or in ICU, and not just in these patients, but even their family members, caregivers, and general population at large. So COVID has not just caused physical symptoms, but it has also increased the psychological distress in individuals, which is the shadow pandemic of this ongoing. Individuals is usually depression and anxiety. So that is why today's session is quite important, because we'll be discussing about how to manage depression and anxiety in general practice. And I think that it's important to understand that anyone can manage psychiatric symptoms like depression and anxiety who have qualified MBBS because we know there is an acute shortage of qualified mental health professionals in the country. So it becomes important that people who are doing general practice are able to identify, pick up, and adequately treat common mental disorders. And today's presentation will be focusing on the same. Go looking into the problem statement of this issue of depression and anxiety, I would like to bring your attention to the graph shown in this slide, and it shows that the prevalence of mental morbidity in toto is around 10.6, and out of this, majority of the contribution is by common mental disorders. So common mental disorders are basically depression and anxiety largely, and severe mental disorders are schizophrenia, bipolar affective disorder, and similar severe illnesses which are quite debilitating. However, it is important to understand that many of us can easily identify severe mental disorders. Even family members can identify severe mental disorders in their own family, because the patient would be quite dysfunctional. However, it is an art that one has to develop to identify common mental disorders, and unfortunately the iceberg of common mental disorders can only be identified after thorough understanding, because it does not cause major dysfunction or impairment. So many a times it is missed and taken as just another emotional issue or emotional problem over which the individual can tide over, but many a times that is not the case. So, talking about common mental disorders, I would be talking in terms of the ICD-10, which is the classificatory system that is largely followed internationally and was developed by WHO to help understand psychiatric illnesses. And it is not just for psychiatric illnesses, it is for all medical disorders. So the ICD divides the symptoms into, or the syndromes into, mood disorders and neurotic, stress-related, and somatoform disorders largely. If we go into mood disorders, we will be focusing today on depressive episodes, or the nomenclature that is given by ICD is depressive episode, and it is coded as F32, and it is classified into mild, moderate, and severe. And severe can be either with the presence or absence of psychotic symptoms. We will be discussing about each of these later independently. There is something known as neurotic stress-related and somatoform disorders, which are coded as F40, F41, and F43.1 respectively, and it entails phobic anxiety disorder, other anxiety disorders, and reaction to severe stress, or PTSD, which is post-traumatic stress disorder. If we come to the this graph that is shown on the slide, we can see that compared to probably the most burdensome psychiatric illness, which would be substance use disorders like tobacco, alcohol, etc., anxiety disorder and depressive disorder comes to a close second or third if you see the depressive disorder lifetime prevalence and current prevalence are around 5.25 to 2.68 respectively, and for the second category that we discussed of neurotic and stress related disorders, 3.7 is the lifetime prevalence, and the independent burden of each independent neurotic spectrum disorder is mentioned in this graph. I will not go into the details. And even PTSD, we might feel that PTSD is a rare diagnosis, but I think 0.24 current prevalence of PTSD highlights that it is probably something which is under identified rather than under prevalent. So we need to be aware of these things whenever a patient comes to us, and we need to know that these common mental illnesses are even though may not be as disabling as severe mental illnesses, their prevalence outweighs them considerably. So we need to know how to treat and manage these common mental disorders, because these can be done by general practitioners as well, as I have discussed previously. So if we go into particular independent illnesses, we'll talk about depression. Depression, as we all might have heard this term, and many of us use it very loosely, that I'm depressed, or my exams didn't go well, or my girlfriend or boyfriend left me, I'm depressed. But depression has a technical diagnosis and has to meet a particular diagnostic criteria and is different from just sadness. So depression is the most common major mental illness, with a lifetime prevalence of around 8 to 12% according to the WHO, and it has been found that ecologically it is more common in women compared to men. And as we will be talking mostly in context to ICD-10, the core symptoms for a minimum duration of 2 weeks need to be present. So it has to be 2 weeks of continuous or pervasive depressed mood, lack of energy, lack of pleasure, which in psychiatric terms is known as anhedonia, or absence of pleasure. So hedonism is deriving pleasure from things, and anhedonia is absence of pleasure or loss of pleasure. So as you can see, these symptoms can present either together or as a combination of different permutations and combination, or even singly. So the other symptoms that are called the minor symptoms are usually reduced attention and concentration, reduced self-esteem and confidence, ideas of guilt and unworthiness, bleak and pessimistic views about the future, suicidality, and disturbed biological functioning characterized by disturbed sleep and appetite. So if you want to simply understand these things, you can divide them into problems with self, problems about the world, and problems about the future. So problems with self could be reduced self-esteem and reduced attention and concentration. Then there could be ideas of guilt and unworthiness. Then you have bleak and pessimistic views about the future, or hopelessness. And regarding the society at large, it could also be helplessness. And these three, helplessness, hopelessness, and worthlessness, form an important cognitive triad, which is also known as the Beck's triad, comprised of hopelessness, helplessness, and worthlessness. So as I discussed, these symptoms again can either be present. It is not an all or none phenomenon, and they can be present in different combinations. So talking about the classification of depression into mild, moderate, and severe episode. So mild episode would be in the terms of 2 core systems plus at least 2 cognitive symptoms that we discussed. So the first 3 symptoms that we discussed are basically the core symptoms, and the rest are the cognitive or minor symptoms. And at least 2 of the major or core symptoms need to be present for a period of at least 2 weeks, along with at least 2 of the minor symptoms, and then we can qualify it as mild episode. Similarly, moderate would be 2 core symptoms with any combination of 3 or 4 minor symptoms, and severe depression is usually the presence of all 3 of the core symptoms along with at least 5 of the cognitive symptoms. So there is a separate specifier for these episodes, which is with or without somatic symptoms, and it can either be present, or if it is absent, it can it is called without somatic symptoms. And the criteria for diagnosing this specifier along with depression would be having 4 or more of the somatic symptoms present. We will be talking about somatic symptoms in the next slide. So somatic symptoms basically means that along with the core symptoms and cognitive symptoms or minor symptoms of depression, the individual will have some biologically predisposed somatic symptoms or bodily symptoms like loss of interest, lack of emotional reactivity. If the event is a joyful one, the individual does not receive any joy in that. Or similarly, in terms of not just happiness, it could even be in the form of if some depressive incident or some stressor has happened, he may not be able to even feel grief or sorrow for that. So that is called lack of emotional reactivity. Waking in the morning approximately 2 hours before the usual time of awakening, and categorically depression is usually worse in the morning. There are psychomotor disturbances which could either be psychomotor retardation or slowing of the psychomotor activities, or it could be psychomotor agitation, which is increased psychomotor activity, and loss of appetite, weight loss, which might even be significant weight loss, more than 15% of weight loss in the stipulated time period, and last but not the least, loss of libido. And loss of libido is something which we usually do not ask in our usual practice. However, it is an important somatic symptom and should be checked therefore. So the differential diagnosis of a person who comes with you with pervasive sadness of mood, anhedonia, and decreased sleep appetite and other minor symptoms, you need to understand if it is a single episode, if it is a multiple episode, or it is a persistent episode. So a single episode, if we look closely to this whiteboard, a single episode would seem something like, so if this is the individual's lifeline and the individual comes to you at this point, and he has come to you for the first time and he says that he has symptoms of depression that we discussed just now. First time that he's coming to you. Before that he's never had a depressive episode, so there is a dip in his mood, and this is the first time that he's had it. So it meets the criteria for either mild, moderate or severe depression, and at this stage, if the individual comes to you, we'll probably call it as single episode, because there have been no prior episodes. So this is the first episode, and the diagnosis would be depressive episode. Similarly, if the individual comes to you with history of first time coming to you, and he says that okay, I am sad, but you feel that there is no impairment in his functioning, or he is largely functional, and the depressive symptoms are of a duration less than 2 weeks. So there is something known as subsyndromal depression. So if the depressive symptoms do not meet the criteria for depression, and or the duration of time is not met to diagnose the episode, it is called as subsyndromal depression. Similarly, if the individual comes to you that okay, I have a depressive symptom, but in the past also I have had such symptoms, and they have all met the criteria for depression or subsyndromal depression. So this might be the third, fourth or fifth, any number of episode for the individual. Then this would probably be called RDD, or what we call as recurrent depressive disorder. So the depressive episodes have recurred, and the individual has come to you to his third or fourth, nth number of depressive episode. Similarly, in a patient in which there is history of he has come to you in depression, however in the past he has had a history of mania or hypomania. So mania is increased energy levels, euphoric or dysphoric mood, increased concept of self, grandiosity. And if he has come with a history of such an episode which has lasted for more than a week. So he has one pole of mania and the other pole is of depression. Then this becomes a bipole, or we call it as bipolar disorder. And the third important aspect or understanding concept is what is dysthymia or persistent depressive disorder. So in this, usually the individual will come to you with symptoms of depression, which may or may not be meeting the criteria for depression. However, he would be having it for a long period of time, and he has been upset for a long period. His mood has been low, and he may or may not be meeting the criteria for syndromal depression, but he may be having subsyndromal depression, as we discussed previously. And if this continuous period of low mood is for more than a period of 2 years, we call it as dysthymia. So dysthymia is if the individual has persistent low mood for a period of more than 2 years, and in between, never for more than a period of 6 months, he has had symptomatic remission, in the sense that his symptoms have not reduced, or he has not reached his actual or usual level of functioning for a period of 6 months. Then this individual will be having dysthymia. If in the background of this low mood of subsyndromal depression, he has a further worsening of mood, wherein his low mood is further worsened, and he comes to you when he has major depressive symptoms, we call it as double depression. Because in the background of dysthymia, the individual has started to have further lowering of mood, then this is called as double depression. Okay. So this is in terms of depression, and we need to understand these concepts. So what are the different forms of depression? The different forms of depression, as I've put on the slide, could be typical or atypical. In typical depression, the symptoms that we discussed are usually present. However, when the individual comes to you, usually in a adult age group of adolescence or young adulthood, we need to rule out if he has atypical symptoms of depression. He may have sadness of mood, but as we discussed, he may not have biological symptoms of depression, like his sleep may actually be reduced. He may be sleeping for 10 to 12 hours in a day, and his appetite may not be reduced. He may be eating much more than usual, and especially there is something known as tyramine craving that has been mentioned in literature that these individuals may have, or tyramine is found in chocolate, etc. So he may actually have increased craving for that, and also he may have increased emotional sensitivity, which is usually found in this age group, wherein they have problems with their parents or any authority figures. So that is typical versus atypical depression. Then there is something known as exogenous versus endogenous depression. So endogenous depression is something which has a biological underpinning, in the sense that it is not reactive in nature, and exogenous depression is something which is usually reactive in nature, in the sense that it is preceded temporally by a psychosocial stressor. Endogenous depression is something which does not succeed a psychosocial stressor, and is just like any other medical illness, and is basically explained as an imbalance in neurotransmitters in the brain. And there is an importance in this differentiation, because the treatment that we give for exogenous endogenous depression is a little different. Endogenous depression usually would react to ECTs and MAO inhibitors. So we need to take a look into that. Then if we talk about the age of presentation, it is late life versus childhood. So late life depression is usually characterized by agitation, by irritability, by hypochondriasis, wherein the individual may feel that he has some severe illness. And childhood depression is usually characterized most by irritability, behavioral symptoms, separation anxiety. So these two age groups may be different from the adult age group, which predominantly shows the symptoms that we discussed. Then there is something known as postpartum blues and postpartum depression. So many a times postpartum females may have problems after their pregnancy, but this usually resolves within a week. And if it does not reach a syndromal level, it is called as postpartum blue. However, if it reaches a level of significant dysfunction, wherein the individual is not able to take care of her child and herself, then it is called as postpartum depression, and it does not remit within the 7-month period of 7 days period of the symptoms. Okay, so about endogenous treatment, endogenous depression treatment, if we look clearly, the literature actually says that instead of SSRIs, substance pharmacological treatment with TCAs, I mentioned MAO, I think, monoamino oxidase inhibitors, not that. Tricyclic antidepressants are the treatment of choice, and in exogenous depression we usually end up giving SSRIs or selective serotonin reuptake inhibitors, about which we'll be discussing subsequently. So now we've completed depression. If we look clearly now, we have to talk about fear and anxiety. So fear, we all have felt fear whenever we have broken something in the house and our mother is waiting for us. After finding it out, we are afraid, we are fearful, and especially in the age group that this audience is in, undergraduate courses, before exams or before their practicals or vivas, fear is a common emotion that we all feel, and it is a stress response from immediate danger. I know vivas or practicals are not immediate dangers, but still they are comprehended as dangerous situations, and it is related with fear. So in this picture, there is a shark behind a fish, and obviously it has a fear of the shark, which is understandable. However, anxiety is different from this, and anxiety is a stress response just from your thoughts. In the absence of an actual threat or an impending risk, you are afraid. So in this, what if the big bad fish comes out today? So even though the shark is not actually following the fish, but the anticipation of this risk or the thought that this might happen in the absence of actually it happening, it aggravates the person's emotions and he feels anxious. And anxiety is a psychiatric illness and needs to be treated. Fear, on the other hand, is not. So if we talk about the anxiety spectrum disorders, we have panic disorder, we have generalized anxiety disorder, and phobic anxiety disorder. So these are the three major anxiety spectrum disorders, and it is an interesting thing to know that anxiety has an evolutionary importance also, in the sense that around the age of 10, specific phobias are usually more common, in the sense that most children will be afraid of, say, snakes or blood or sometimes loud noises, because it is an evolutionary mechanism, in the sense that it has been passed over genes and epigenetics that these things are dangerous. So even a newborn might be afraid of these things, and that is why the usual age of presentation of these things could be age 10 for specific phobia. Similarly, as an individual grows into puberty and reaches the age of 15, he becomes consciously aware of himself, and he is afraid of being judged or being assessed by other people. So this is the usual age of onset of social phobia. When we come to the age of 20, we are exposed to a new system of regulations. We move out from the protection of our family, and we have to follow we are exposed to a lot of things like sex, religion, and violence. So this is usually the time that something like OCD develops, because some rigidity in your behavior might be fostered by this sudden exposure to these three things. Then age 25, agoraphobia, about which we'll be discussing later, and as we reach age 30, we have this vague kind of loss of control over ourselves. Along with that, there is a newfound individualism or autonomy, and there is some inconsistency or some vagueness in that, and that is the usual age of presentation for GAD or generalized anxiety disorder. We'll be discussing all of them individually. So if we talk about GAD, as per the ICD-10, there has to be minimum symptom duration of 6 months, and that has to include apprehension, motor tension, and autonomic overactivity. So apprehension would be this free-floating anxiety wherein throughout the day you feel afraid about something, and it could be something about, say, the well-being of your family, to will you ever be able to do something successfully in the life. There is no particular reason for this anxiety, but it could be precipitated or worsened or exacerbated by any ongoing activity, and it is present throughout the day, not limited to any particular activity or particular person. So this apprehension is often paired with motor tension, wherein your body might be stiff, tight, or you might feel heaviness in your body or tautness in your body, and it is also accompanied by autonomic overactivity. So there is a cognitive component, which is apprehension, then there is a physical component, which is motor tension, and then there is a biological mechanism, which is autonomic overactivity. And these symptoms, as I've shown in the next slide, could be shown by rapid heartbeat, stomach issues, sleeping problems, memory issues, trouble in breathing, sweating. So these are all things that can be present in GAD for a minimum duration of 6 months. Then we come to this concept of panic disorder, wherein panic is characterized by recurrent attacks of severe anxiety, at least 3 or 4 such episodes in a month. So no objective danger, in the absence of any objective danger, and without being confined to a known predictable situation. For example, obviously if you are put in front of a terrorist or someone who is going to assault you, you are going to feel afraid. However, in the absence of an imminent or objective danger, and without being confined to known or predictable situation, for example, if I know that I am going to be put in a room with snakes, I will be afraid, I will be fearful. However, if both these things are not present, and with inter-episodic freedom from symptoms, in the sense that there is no objective danger and there is no confinement to a particular situation, I am able to delineate my fear, in the sense that when I'm thinking about these things, that is the time I may have these problems. However, the inter-episodic period between two panic attacks is usually symptom free. However, it may have some component of anticipatory anxiety, wherein I am afraid that such an attack can happen to me at any point of time, and I am in anticipation that it can happen to me any point of time. What will I do then? What will happen to me? And this is present even in the inter-episodic period. And as we know, panic symptoms have been shown in the next picture, that there could be sweating, dizziness, pain in the heart, a heart attack, and you might die, and a lot of things that we will discuss later also in the subsequent slides. Panic, usually patients will say that when I get a panic attack, I fear that I may die, and it is a major problem, and it is a life-threatening issue. However, it's a myth, and the fact is that they may fear it, but it is not a life-threatening problem, and it is just that the symptoms are misinterpreted as a serious cardiovascular respiratory issue, and this further increases the anxiety of the individual and can worsen the panic symptoms. So then we have talked about GAD, about panic. Now we come to phobia. Here there is a well-defined situation or object, unlike in panic, wherein there is no situation or object in particular that the individual is afraid of. And this situation or object may not be inherently dangerous. For example, you might have seen that some girls are afraid of, say, lizards or cockroaches, or some boys may be afraid of heights. So even though such situations, or for example, a simpler situation would be going to a market. So going to a market is not inherently dangerous. However, these individuals may find the situation, which is a well-defined situation, going to the market, as very dangerous, and they may have psychological, behavioral or autonomic symptoms similar to what we have discussed before, which is accompanied with avoidance. So avoidance means that I want to avoid this well-defined situation or object, and in this example, which is also known as agoraphobia, there might be an avoidance of going to the market or going to any open space from which escape is difficult. Alright, so there is a non-inherent dangerous well-defined situation, and it is accompanied by these symptoms along with avoidance, and this is known as phobia. And there are various kinds of phobias. It could be agoraphobia, it could be social phobia. Agoraphobia is usually a fear of being able to escape from a place, and agora comes from the word market, and usually these markets are supposed to be very busy, and individual might have a fear that he may not be able to escape from this crowd. And social phobia is anxiety that occurs in context to social situations or relations wherein the individual has a lot of fear of being judged or his actions being assessed or judged upon by individuals around him. So before I go to the next slide, again, if we come back to the board, we've discussed about GAD. So GAD would, if this is the baseline of the individual, GAD is like a free-floating anxiety. So it is present throughout the day and for a minimum duration of say 6 months, and it could be about anything. That it could be about if I will be able to do a task, will my family reach in time, what will happen to the world. So it can be as open and vague as that, and it is present throughout the day, not specific to any task or any situation. If we talk about panic, so in panic the individual will have these panic symptoms wherein there is palpitations, hyperventilation, impending feeling of doom, GI upset, and in between these periods he will be symptom free in the sense that he will not have panic symptoms. However, some form, as we discussed, anticipatory anxiety can be present, that when will the next attack happen, and these are usually short lasting attacks and usually self terminate, and they come without, if you notice, there are no preceding stressor or objects before this. So this is known as panic attack. However, if in the same thing I put in a particular object, for example, if I put in say, again, a market open or say closed spaces, and whenever the individual is in a closed space, which may not be, see, we all use lifts or elevators in today's world, so it is a closed space and we don't feel debilitatingly afraid of it, as in we have this symptoms of panic whenever we are using a lift. However, in an individual who has claustrophobia, or which is a fear of closed spaces, whenever he is in an elevator or any other closed space, he will have these symptoms of panic. Interestingly, wherever he is not in a similar place or similar situation, he will largely be symptom free, in the sense it is not going to really affect him unless he is exposed to this particular object which is not inherently danger per se. However, this panic symptom will come repeatedly whenever he is exposed to this stressor. He will not have these symptoms in the absence of these in the absence of this object. So if we remove that object, these symptoms will not be there usually. And also we need to know that subsequently, because the person learns that if he is not limiting himself to this situation, he does not get these symptoms. As we discussed, there will be something known as avoidance, wherein the individual will himself try to avoid these situations so that he does not get symptomatic. So these are the three major parts of anxiety, which is GAD, panic and phobia, and how they are different. Now, if we go to overlap of MDD, which is major depressive disorder, and anxiety disorders, I wanted to highlight that there may be a considerable overlap in symptoms. If you see, we discussed about sleep, concentration, fatigue, psychomotor difficulties, which could either be arousal or reduction. And if you see the bold 4 puzzle pieces, you see that there is overlap in both depression and anxiety in context to these domains. However, you need to understand what is at the core. So in depression, the core is usually depressed mood or reduced interest or pleasure, which is known as anhedonia, and it is usually associated with, say, suicidality in some cases, or feelings of guilt, worthlessness, that we discussed as the cognitive triad. So there is a strong cognitive depressive triad in patients of depression. However, in anxiety, it is more about this feeling of worry or feeling of anxious feeling of anxiety, and it is associated with, as we discussed, irritability, muscle tension, could be in the form of panic or phobia. Alright, so you need to differentiate, because sometimes when you are monitoring for response, you need to see what symptoms are improving, and unless you know what are the core symptoms of respective disorder, you will not be able to monitor for response or symptomatic remission. So if we now come to post-traumatic stress disorder, which was interestingly, a fresh breakthrough in psychiatry. So the World War time was a period when post-traumatic stress disorder really came into importance, because many of the soldiers who had worked in the war setting had many of these symptoms, and it was worrisome to the army because they were losing men because of that, like they were not able to function properly. So it was actually previously known as shell shock, because the individuals who were exposed to these detonation of these bombs, they were having these symptoms because they were experiencing a lot of violence, a lot of loss of life in front of their own eyes, dismemberment of individuals. So all the war atrocities that were noted by them. And that is when this concept came of post-traumatic stress disorder. ICD currently diagnoses it that within the 6 months of stressor. So now, since everyone will not be facing a war, but it could be something. Stressor could either be like an instance of sexual abuse, an instance of being, for example, being violated by a group of individual, or rape, or usually it can be following a road traffic accident, or you witnessing a murder or something like that. So that stressor, within 6 months of that stressor, you have symptoms of emotional detachment, wherein you feel that you are not able to emote to anything, like not feeling anything, and you feel detached from everyone. And there are flashbacks. So flashbacks are usually reliving the experiences or memories of that stressor that happened. For example, if it was a road traffic accident, you are getting images of that road, that car, that traffic incident, dead body or blood. So these are the flashbacks that may happen. And similarly, you can have daytime imagery, wherein you may you be reliving these experiences within your day-to-day working. And this might be associated with numbness, wherein you might be feeling emotionally numb, and anything that happens around you, you don't feel you don't have the capacity to understand it properly and react to it. And it can also be accompanied with vivid dreams or nightmares. And subsequent to what we had discussed previously, there will be an avoidance of any triggers or stressors that remind you of that incident. So in PTSD or post-traumatic stress disorder, usually we talk about two major differentials, which are acute stress reaction and adjustment disorders. So acute stress reaction will be different from PTSD, because it will be, if we look again at the board, PTSD, as we discussed, will be starting, say if here is a stressor, it starts within 6 months of this, and the patient becomes symptomatic. However, if the symptoms are starting almost immediately after the stressor has occurred here, for example, they're starting here, and they, the symptoms remit within a few days of onset, it is usually called as acute stress reaction. And acute in onset, and it is a transient thing, and it remits within a few days, starts within a few hours and remits within a few days at the maximum. So then it is called acute stress reaction. However, if it starts within a month from the stressor, like for example here it is starting, and it resolves within 6 months, so it is within 1 month of the stressor, and usually of a lesser severity compared to post-traumatic stress disorder, and resolves within 6 months. It is called as adjustment disorder. Adjustment disorder has various types. It could either be depressive, brief depressive, brief anxiety, or other various subtypes which are probably outside the purview of this presentation. And so these are the basically three broad categories that we need to understand: depression, anxiety, and stress related disorders like PTSD, acute stress, and adjustment disorders. So from you as undergraduates, I hope at least few of you are interested in psychiatry, and even if you're not interested in psychiatry, what are the expectations that we have from general practitioners when you become MBBS graduates to take heed of during this coronavirus outbreak and even beyond it? We expect that a GP should be able to do a rapid screening in all adult patients for possible psychiatric disorders. So if a patient comes to you and he may not be reporting actively of depressive symptoms or anxiety symptoms, which is usually the case with the Indian population, that they are not able to express these emotional symptoms or cognitive symptoms correctly, and they may come under the facade of physical symptoms, wherein I have some body pain which is not improving with analgesics or with no known etiology, and the patient continues to be symptomatic. So there is something known as somatization of symptoms, about which again we will be having a class. So you need to be able to pick up these common mental disorders in patients coming to you, and you should be able to diagnose and give the first line treatment, and also provide some brief counseling to these individuals. If patients show improvement with treatment in 3 to 4 weeks, you need to consider following them up under their own care. And if case in the sense that under your care, if the patient is showing improvement and is stable, does not require further referral. And when do you want to refer? If the case is unclear, you refer to a psychiatrist. In stable patients who are referred by a psychiatrist for follow-up, you need to clarify information with a reliable source like family or friend, inquire about their clinical condition on all follow-ups, check for the side effects of medications, and prescribe some medications when same medications when the clinical condition is maintaining well, or there is improvement or not worsening. If the patient is not improving or there are severe side effects, becomes suicidal or aggressive, you need to refer him again to a psychiatrist. And when they ask questions as to how long the medications need to be, if there are particular advices which you are not able to give, again you can refer to a psychiatrist. So what kind of patients are usually prone to have psychiatric illnesses when they come to a GP? They are usually patients who have been getting repeated prescriptions from general physicians, like as I mentioned, pain, like analgesics, multivitamins, that you give me some medication for my problem. And in general practice we might say that okay, like these multivitamins may have a placebo effect. They may be asking for things like give me some Shakti ka dawai or some energy syrup, and they may say I am not able to work without that. They may be reporting repeatedly of unclear GI disturbances or GI symptoms which have been evaluated but nothing has been found, sleep disturbances, and repeatedly saying that give me some fluids so that I can get better without any proper indication. Thus, these are all patients that you might have seen in your practice or in your internship or in your clinics when you have rotations in medicine, surgery, etc. So, thus you will always be, irrespective of if you join psychiatry or not, you will be coming across such patients, so you need to be aware of how to deal with them. So this is basically a screener or record form wherein you have to write in the socio-demographic details of the individual, check for any pre-existing mental illness or any treatment history, including substance use. You document the complaints, and usually it is best to note down the patient's complaint in their own words. Examine them physically, just that you are sure that you are not missing out any physical disorder, because many a times there might be a combination of both physical problems and mental problems. So you need to be aware that physical examination is as important in other branches as it is in psychiatry. Then you need to understand that if these above symptoms can be explained with a known medical illness, if they are able to explain, you are able to explain, then you go ahead with evaluations and treatment pertaining to that. If the illness is less than 2 weeks and you're not able to put it in a particular constellation of symptoms of medical illness, you need to reassure and ask them to come for a follow-up. But if the symptoms are usually more than 2 weeks, then please check for psychiatric problems in the individual. And usually we check this by looking into the functioning of the individual, and the functioning of an individual is usually checked by his biological functioning, his social functioning, and occupational functioning. So his biological functioning would be checked by his sleep and appetite. His socio-occupational functioning would probably be checked by his ability to go regularly for work. in this screening questionnaire, if you want to, if I've highlighted it in the box, if you are able to ask the patient that did you get sudden attacks of fear or anxiety that we discussed, it would probably amount to panic disorder, and these attacks were without any reason. So we have understood now that panic means fear of sudden nature without any known reason. So we understand that it's going to be panic. So if these two symptoms are present, yes, panic. If there are in the past few months you have been feeling tense or stressed without any reason or out of proportion to the reason or the task, and you are unable to control and you have behavioral or cognitive or emotional symptoms, then as we understood it would be GAD. Then if you, for depression, if there is tiredness, there is decreased interest, as we discussed, anhedonia, the three core symptoms are present, there is a high likelihood that the individual has depression. Similarly, for once you have identified that, then you need to understand the diagnosis, and as we've discussed, it could be predominantly depressive, it could be either anxiety, or it could be mixed disorder of anxiety with somatic symptoms. When we are managing this individual, we need to understand that we want to discuss the ICD criteria for all of these disorders, and we have already discussed all of them in the previous slide, so I'll not go into the details, but these criteria should be briefly understood so that such a patient comes to you. You do not miss out on panic, on GAD, adjustment disorder, acute stress reaction, or post-traumatic disorder. So if the acute stress reaction symptoms are usually lasting for more than a few days, especially if more than a month, it will probably translate into post-traumatic stress disorder. Alright, so similarly with depression, as we discussed the core symptoms and additional symptoms, so these are verbatim from the ICD, and you can have a read or understanding of this from these slides. Once a patient has been diagnosed to have any common mental disorder, you usually, like other medical specialties, you would like to do some investigations. However, I would want to highlight here that for any mental health professional, the best investigation is the interview that you have with the patient and his family, and that is not only a screening investigation, it is also a diagnostic investigation, because we are not able to diagnose any of the psychiatric illnesses by either an imaging or blood tests. Nevertheless, we need to do certain investigations like TSH, ECG to rule out any medical comorbidity, which can also have some neuropsychiatric manifestations, because we all know that hypothyroidism can present as fatigability, lethargies, low mood, decreased appetite, reduced sleep. So we need to rule out that. Similarly with hyperthyroidism, ECG could, like even sometimes you need to know that cardiac arrhythmias or other cardiac abnormalities can also mimic panic, or the other way around, panic can be mimicked by these things, and you may underdiagnose this individual. And CT, MRI of brain are rarely used in routine clinical psychiatry, but can be used when the individual is not improving despite adequate adherence to treatment, or his symptoms are worsening despite being on medications, or he is having severe side effects. So what are the treatment guidelines? If we look, the onset of action is usually around 2 to 3 weeks and takes around 4 to 6 weeks for full action. So this becomes important because unlike say some antipyretic that you give today and the effect is shown within few hours, most of the psychiatric manifestations, psychiatric medications take some time to build up in the body and to regulate the neurotransmitters and show their full effect. They usually take 4 to 6 weeks. So you have to tell the patient that they should not be afraid that, I'm not improving. I've been taking the medication for 2 days, 3 days. There is no improvement in symptoms. You need to tell them that for the full effect, we need to wait for a month or month and a half. Usually the medications that we start are given till 6 months. So once the patient has shown improvement at a dose, we tell them that you might have to continue this medication for around a period of 6 months roughly, and you should not stop these medications abruptly unless there is a severe side effect, or if there are any side effects, you should come and discuss it with the doctor. So if we go into the particular disorders, we can see that adjustment disorder and acute stress reaction, the treatment is usually benzo benzodiazepines and counseling, and probable duration of treatment is 2 to 3 weeks, which could be more depending on the severity of symptoms. Predominantly, if there are depressive or anxiety disorder or even post-traumatic stress disorder, the first line of drugs is SSRIs to manage the symptoms of, say, acute distress, for example, agitation, disturbance in sleep, extreme dysphoria, suicidality. Sometimes we do prescribe benzodiazepines for the tiding over this difficult situation. However, main treatment remains SSRIs for 9 to 12 months. However, initially we can give 2 to 4 weeks of benzodiazepines. If it is a predominantly mixed episode, as we discussed, for endogenous depression, similar to that, even in mixed disorder wherein you have a combination of depression and anxiety and some somatic symptoms, we usually give TCAs, and it is given for a period of 1 to 2 years. So here is a list of the usually used medications, and as we discussed, SSRIs are usually the first line of drug. Commonly prescribed here in NIMHANS is fluoxetine and escitalopram along with sertraline, because they are relatively safer drugs, easily available, and have lesser side effects and good response in patient. Fluoxetine specifically, if you need to know, is preferably given in the morning because it has some activation, so sometimes if given in the night it may cause sleep disturbances. Escitalopram, when given in old patients, should be monitored for hyponatremia symptoms. Sertraline is safe in old patients and is actually the drug of choice when the individual has multiple medical comorbidities. Newer antidepressants are also present, like venlafaxine, mirtazapine, bupropion, which again have their particular indications, which are probably at this stage of undergraduation out of the scope for you people. However, TCAs are older antidepressants, and they are usually avoided now because they they usually have more side effects. As you can see, the number of plus signs in front of TCAs is much more compared to the SSRIs. So you need to know that importantly in SSRIs, sometimes there are sexual side effects, which are many a times the reason for patients to stop medication. So whenever you are talking to patients, do look out for things like delayed ejaculation, retrograde ejaculation, reduction in arousal, or anorgasmia. Benzodiazepine, as we discussed, usually we prefer clonazepam or lorazepam because they are easily available and easy to dose. Clonazepam is relatively longer acting, so it is given best for patients who are in the younger age group. Lorazepam, due to its shorter acting nature, is probably preferred in elderly. However, there are no clear guidelines for the same. It can be used for patients who have problem with sleep, who are acutely agitated, as I discussed, suicidal. However, you need to know that benzodiazepines do have a potential of addiction as well as abuse, and can also be used to overdose in terms of suicidal patients. So we need to count the number of tablets that we are giving, make aware the family members that these many tablets have been prescribed, and if the patient is acutely agitated or suicidal, best that the medications are monitored by the family. So that is the pharmacological part. There is the second arm of psychiatry, which is counseling or psychotherapy, which is as important as pharmacotherapy, if not less. We need to counsel them briefly within 5 minutes. That it is similar to things that we tell our outpatients in other departments, but here we have some special things like education about illness, because many a times the patient and the family may not be able to understand what a psychiatric illness per se is, what are the psychiatric symptoms that the individual has, and we need to warn them about what to know warning signs are, what to know when they need to be taken to a specialized care. So counseling would include information about nature of illness, that it is just like any other medical illness, has a biological phenomenon, and usually we say that the psychiatric illnesses have a biopsychosocial model wherein there are certain biological mechanisms which, when interact with the psychosocial environment of the individual, manifest as psychiatric illnesses. So that would be about the counseling part, and we tell them about the need to be compliant to medications and treatment and come for regular follow-up so that we can monitor for symptomatic response as well as any side effects. We also provide practical tips to handle stressors whenever present, and you need to understand that there's a difference between counseling and psychotherapy. Psychotherapy is done by a specialist and is a multi-session therapy, and is probably given by mental health professionals best, like psychologists and psychiatrists. Counseling is something that even general practitioners can do. So what do we do when there are comorbid medical illnesses in these individuals? We know that psychiatric disorders, it has been shown by multiple studies that psychiatric disorders can be present in all major medical illnesses like diabetes, hypertension, IHD, stroke, cancers. So what we do is we try to minimize multiple medications. We begin at a low dose and we go slow. So it is start low, go slow. However, this schedule should contain, we usually prescribe, as we discussed, something like sertraline in these patients which are relatively safe. If you feel that the case is too complicated, complex, or is not improving with your interventions, always do refer to a psychiatrist. Another vulnerable group, just like elderly and children that we discussed previously, is the perinatal group, which includes psychiatric disorders in pregnancy and during lactation. And unlike popular opinion, general rule of pregnancy and lactation is applicable for psychiatric disorders also, such as avoid in first trimester, caution in second and third trimesters. What I was trying to say is that it is not an absolute contraindication. There are medications that are safe for females who are breastfeeding or pregnant, and it is not that these medications have all psychiatric medications have an adverse effect on the fetus or during breastfeeding in the newborn. So since it's a specialist topic, I think it's best to refer to a psychiatrist in view of avoiding any untoward incident. So when we are prescribing, how would your prescription look like? It would, for example, if I look at the first column, we are prescribing fluoxetine, and as I mentioned, we are prescribing it in the morning to be taken as a tablet. Along with that, we have prescribed clonazepam because the patient might have some distress which may not be taken care by fluoxetine. As we discussed, the full effect of antidepressants or most of the psychiatric medications comes over a period of 4 to 6 weeks. So till then, for the initial part, we do give benzos or benzodiazepines. We also, as we discussed, counsel the patient that the action of the medication begins in 2 to 3 weeks and full action will come only in 4 to 6 weeks. And usual course of treatment is 6 to 9 months for depressive and anxiety disorders. However, we call them for regular follow-ups, not just to ensure that they're taking treatments, but also to watch out for worsening of symptoms, and in most depression patients, to look out for suicidality. So that becomes very important. If the individual is not improving after follow-up or say a month of taking medications regularly, you need to refer them to a psychiatrist so that further help can be provided. Psychological management, as we discussed, this is again a level above what we are expected to do in general practice. However, in our interventions, we can be brief. We, as we discussed, explain about the illness, expectations from treatment. There's not going to be a miracle cure. Everything is going to take time. How to handle stress, improve the sleep, expected action of medication, and duration of continuing the medication. We do also want to highlight that we also just not talk to the patient in psychiatric conditions. Many a times it's best to take consent from the patient or the client in front of you to say that, can I discuss it with your family? If they are okay with that, you can discuss things with the family, like educating them about common mental disorders, helping them to identify stressors and how they can help the patient in mitigating the effects. Sometimes there is the caregiver burden, which means that the people who are taking care of the patient may be exhausted or may be burdened by the patient's needs and may have some caregiver burden. That itself could manifest as psychological distress, as symptoms of anxiety and depression. So sometimes we need to address that also. So family interventions are also important in psychiatry. So there is I just wanted to introduce this term, which is commonly used over media right now, and it is known as CBT, or cognitive behavioral therapy. We have many patients who come to us that I want CBT for my depression, I want CBT for my anxiety. At your level, you need to understand that cognitive behavioral therapy is again psychotherapy and is provided by specialists or mental health professionals who have trained in the same. It basically talks about how your thoughts, emotions and behavior are connected to each other. So if you have a negative thought, you will have a negative emotion, and that manifests as a negative behavior. For example, if you have views like I am not good enough or I will never be good enough, that would be accompanied by a feeling of sadness, feeling of inadequacy, feeling of distress, and this may manifest behaviorally as you not wanting to go to work, you not wanting to go to meet people. So many individuals are not able to understand how their behaviors are connected to their thoughts and emotions. However, it is very interesting that CBT is actually the first line of treatment for some of the anxiety disorders that according to some guidelines, and OCD, obsessive compulsive disorder, and I think this will be discussed more in detail when we will be having the class on OCD. However, it's a intervention that we commonly do here at NIMHANS, and all us psychiatry residents are trained in the same. What do we do when the patient has been provided pharmacological treatment, psychotherapy or counseling has been provided? How do we follow up? So first follow-up should ideally be after 2 weeks to assess for side effects. Second, at 4 weeks to assess the effects, in the sense symptomatic improvement, and then every month for maintenance as to refilling of prescriptions or to see if the symptoms are improving and not worsening. So what do we do is, have you improved when compared to the earlier visit? If the individual says no, check the compliance to treatment. In psychiatric illnesses, compliance to treatment is very important. If the individual is not taking it the right way, you need to tell him how to take it, and if despite adequate compliance he is not improving, we refer to a psychiatrist. If the individual says that, okay, compared to last visit, I am improving, I have improved, you tell them that, okay, how much have you improved? If they say that it is less than 50%, probably there is a chance that if you increase the dosage of medicine, the improvement can further accentuate. If the improvement is more than 50%, I think that would be a good dose, and you continue with that medication. We've already discussed that for depression and anxiety, usually we continue the medications for 9 to 12 months. In case there is a worsening or there are problems which you cannot handle, like suicidality or aggression, wandering away from home, you do refer to a psychiatrist. So when do we refer? What are the red flags? This is the last part of the presentation. If there is no improvement after 4 to 6 weeks, as we discussed, despite regular compliance to treatment, we refer to a psychiatrist. If patient is suicidal or aggressive, refer to a psychiatrist. What we do is, there is a concept of psychological first aid for patients, which even a general practitioner can provide, wherein you actively listen to the individual in front of you, try to understand their distress, validate their feelings, ensure them confidentiality, ensure that if you feel suicidal, do seek out help, educate the family that the patient might be at risk of suicide, so they need to monitor the patient. So what are the red flags wherein you have to in all circumstances refer to a psychiatrist if there are severe depression with psychotic features. So psychosis is something which will be covered later. So if there are symptoms like delusions, hallucinations, reduced self-care, aggressive tendencies, homicidal behavior, suicidal behavior, we need to refer. If there are suicidal ideations, harm to self, according to the new Mental Health Care Act, if there is any individual who is at risk of harm to self, which is probably suicidal, or if he's at risk of harm to others, or he is not able to take care of himself or herself. So all these 3 points are covered, and this patient usually requires inpatient care and will best be taken care by a psychiatrist. If the individual's general health condition is deteriorating because of a psychiatric condition, and last but not the least, if he refuses to take medications orally, and not just medications but also his meal, so there is a risk of life to self, not just by suicidal behavior but by refusing food or not taking care of himself or herself, then again we need to refer such a person to a psychiatrist for specialist care. So these are the red flags. We've understood what is common mental disorders, how they are more in prevalence compared to severe mental disorders, how it is difficult to recognize common mental disorders. Nevertheless, we can still do a lot at the general practice or community level to take care of these individuals. What do we mean by depression? How is it different from sadness? What do we mean by anxiety? How it is different from fear? What is PTSD or post-traumatic stress disorder? How do we manage a patient? What are the investigations to be done? What is the treatment to be provided? What the first line of drug is usually SSRIs like fluoxetine and escitalopram. What are the side effects that we need to look for? How do we assess the patient at follow-up? And last but not the least, what are the red flags for referral to a psychiatrist in case the patient is not improving or worsening? And this is the end of my presentation, and we will be talking about many of the other psychiatric illnesses in the future. So I hope you people find these presentations useful, and if any doubts you can mail to us or contact us and we'll see what we can do. Okay, thank you.